is smoking. But that's the next strongest risk factor is lifestyle factors such as obesity, poor nutrition, and inactivity. Other factors such as family history, which we pay a lot of attention to, are much smaller contributors to lifelong breast cancer and other cancer risks. The good news is that mortality following a cancer diagnosis is decreasing in almost every cancer category. So if you look here at this graph, you see cancer rates and over time, or cancer deaths over time. And you can see that breast cancer deaths sort of peaked in about 1990 and have decreased, as have lung and bronchus cancers. This decrease in cancer-specific mortality is primarily attributable to screening. For lung and bronchus cancer, it's to decreasing smoking rates. But we also have exciting new therapies for breast cancer, lung cancer, colorectal cancer, and many other malignancies. Unfortunately, here in the United States, not all racial and ethnic groups are experiencing the same decrease in mortality related to breast cancer. As you can see here, there remains a significant gap between white Americans and African American individuals with respect to survival following breast cancer. And part of this is differences in risk factors experienced by different populations, but it's also related to differential access to health and screening facilities. When we talk about breast cancer, the way that we diagnose breast cancer early is with screening and detection. Unfortunately, it's pretty confusing to tell which screening recommendations we should follow. These are a number of national medical organizations, including the American College of Gynecology, the American College of Radiology, the American Cancer Center, the Society, the American Medical Association, the National Comprehensive Cancer Network, the U.S. Preventative Forces Task Force, and even Trinity Health. And you can see there are differing opinions about what age to start screening, what age to stop screening, how often we should do it. Should we do it every year or every other year? And whether or not we should use either standard mammography or tomosynthesis, which Dr. Knapp will talk to you a little bit more about. So with all of this information, it can be kind of confusing because I'm going to go back one slide. These screening recommendations are for women with average breast cancer risk. So many people are going to want to know, well, how do I figure out if I'm low risk, average risk, or high risk? And that's what we're going to talk about tonight. So breast cancer risk is influenced by modifiable and modifiable risk factors. Individuals with the highest risk for developing breast cancer are those who have certain inherited mutations, such as BRCA1 and BRCA2 mutation, other genes such as P52, another one called P10, another one called PALB2. There are other conditions such as ductal carcinoma in situ and lobular carcinoma in situ, which are diagnosed on biopsy and would increase an individual's risk for developing breast cancer. A moderate risk of breast cancer is associated with certain other pathology diagnoses, mammographically dense breasts, and then a few other genetic mutations and some early exposures, such as radiation for lymphoma. Now, there are other factors that are associated with the low risk of developing breast cancer. And those confer some increase in breast cancer risk, but not as much as the mutations or the pathology diagnoses. And those are elevated BMI, alcohol consumption, a few diagnoses on biopsy, prolonged exposure to estrogen through early menarche and late menopause. But the good news is that there are some factors which protect against breast cancer. And one is exercise, Another is using estrogen alone hormone replacement therapy, which unfortunately not everyone can do, because progesterone needs to be administered along with estrogen in order to reduce the risk of uterine cancer. And also breast cancer is reduces risk for developing breast cancer, breastfeeding. So with all of the information we hear in the media and people that we know with breast cancer, it can be very confusing, and it's hard to know where the facts are. These are some patient-facing campaigns, which you'll see, and many of them are very difficult to interpret. People will tout certain miracle foods, tell you you shouldn't use deodorant, talk about very strange and very rare early signs of breast cancer, cancer-fighting strategies through manipulation of your pH. This has not been proven, but certainly I hear a lot about this. And it's very confusing, and it's hard to tell which interventions are really going to help us stay healthy through our life. And because of what we consume in the media and what we hear from friends, it's very common to have an inaccurate perception of your breast cancer risk. And that can lead to either over or underestimation of your personal breast cancer risk. And so perceived risk is one's individual belief about the likelihood that something bad might happen to them. And because there are so many media reports and daily social contacts, and people meet others with breast cancer, that can lead to a high frequency of thinking about one's individual breast cancer risk. And that can either be helpful or not helpful. You could have content-based worry, which is, oh my goodness, I'm worried that I might get breast cancer, I should get a mammogram. Or it might make an individual so anxious and worried that they would avoid mammography out of the fear that it might show something. So it's important for us as providers to really educate our patients about their breast cancer risk so that they receive the appropriate screening. We have a breast cancer risk assessment clinic at St. Joe's and IHA, and that's to help people sort out the multiple, often conflicting guidelines about breast cancer screening. This also takes some of the load off of our primary care providers. There's a lot for patients and the primary care providers to get through in a primary care visit. This allows us to have an objective estimate of breast cancer risk that's performed in a separate visit dedicated to this discussion. We can reassure women who are at low or average risk, identify those women who have a family history and might benefit from genetic counseling or testing. And then we can identify high-risk women. We can advise them on the appropriate screening, talk about risk reduction, and also talk about clinical trial eligibility. So how do we estimate breast cancer risk? I'm not going to get into the math here, but the two most common risk assessment models that we use are the Gale model and the Tyrer-Cuzick model. And the Gale model is quick. You can do it online. It takes about 5 minutes. The Tyrer-Cuzick model includes more risk factors, including breast density, BMI, hormonal exposure, a more comprehensive family history, but it may overestimate risk in some patients. But these are the tools that we use when we're counseling our patients about their breast cancer risk. There's some relatively new technologies that are available when we are talking to patients about breast cancer risk. One of the new technologies is one called single nucleotide polymorphisms, which I will not say a second time. They are abbreviated as SNPs. And so just to go over this briefly, because you may hear about this, and it is very interesting. Many inherited diseases are associated with a single mutation. And so that mutation may change the function of the gene and result directly in a disease. SNPs are small mutations, maybe just 1 or 2 tiny little base pairs. The base pairs are the language of our DNA that tell us how our bodies are made and how they function. And there can be as many as 4 to 5 million variants within an individual's genome. Now, these variants may be associated with increased or decreased risk. And so how that looks on a map here is this is a map of somebody's genome. And you can see that in the red, all of these variants are associated with a higher risk of, in this example, cardiovascular disease. And the gray ones are associated with a lower risk. And you can calculate somebody's SNP score by comparing the number of SNPs associated with disease with the number that are associated with protection from the disease, and give some additional information to an individual about their lifetime risk of developing disease. Now, we're not using these at this point for calculating the risk of developing breast cancer because they haven't been validated in all populations, but I think it's a very interesting technology that we should keep on our radar over the next couple of years. After assessing an individual's risk and talking to them about what that means, we want to talk to them about modifiable risk factors. What are the things that are in their control to reduce breast cancer risk? One common way to reduce breast cancer risk is to offer estrogen blocking medication. And that's for women who, by the Gale model, have a greater than 1.67% 5-year risk for developing breast cancer. And there are a couple of different medications that we can offer. For the women in the highest risk categories, we sometimes will offer risk-reducing surgery, and that's for patients primarily with BRCA1 and 2 inherited mutations and several select situations. These patients are candidates for reconstruction, or they're also candidates for going flat, depending on their personal situation and their preferences. But I want to talk about things that are a little bit less drastic, the things that we do every day that affect our health. The World Cancer Research Fund and the American Institute of Cancer Research and the American Cancer Society have 4 lifestyle recommendations. Achieve and maintain a healthy life or weight throughout life, adopt a physically active lifestyle, consume a healthy plant-based diet, and limit alcohol consumption. Now, for most of my medical career, I've said all of these things, but I always felt like a little bit of a cheerleader because I didn't really have the science to back it up. So that's what I'm going to talk about today, is the evidence that we now have that doing these things can reduce our cancer risk and at the same time reduce our risk for cardiovascular disease and other chronic diseases. So here's a little chart describing the interaction, and nobody is going to be tested on this, but essentially over here on the left side are examples of a high-fat diet, which is rich in sort of refined foods, meat, low fiber, which taken all together are associated with increased body fat, increased steroids in the body, increased blood pressure and diabetes, all leading to an increase in oxygen-free radicals and an increased risk of breast, colon, and other malignancies. And it's this interaction between diet, the metabolic effects of a poor diet, and then the downstream effects, as I said, high blood pressure, endocrine abnormalities, and an increased risk of these cancers. So what's the data? And I'm just going to show you a couple of studies here. The World Cancer Research Fund and the American Institute for Cancer Research completed the VITAL study. This was a study that looked at 30,000 women, and it's important to understand that these women were identified prospectively, meaning they were volunteers in the study, and they gave them certain recommendations, and they're listed here, 6 recommendations. And they followed these women for almost 7 years. And what they found was that breast cancer risk was reduced by about 60% in women who met at least 5 of these 6 recommendations. And the risk reduction was much less in women who met 0 of the recommendations or a portion of them. The key components were body fatness is their description, but basically BMI, plant-based food, and alcohol consumption. Another study called the EBBA study, Energy Balance and Breast Cancer Aspects Throughout Life, looked at 17,000 women. Now, this study was different because this was a population of women who were followed, but they weren't necessarily volunteers in a study. Among these 17,000 women, 574 developed breast cancer, and then they went back to their medical records and looked at their pre-diagnosis lifestyle factors and compared them between the group that developed cancer and those that did not develop cancer. And what they found is that the risk for developing breast cancer was double in postmenopausal women who had 3 to 5 unfavorable factors, and that mortality was higher in women with an unfavorable lifestyle. And this graph over here demonstrates survival over time. And what you can see is that all the patients are alive over here on the left side and fewer alive over on the right side. And those patients who had no unfavorable lifestyle, there were more of them alive at the end of 5 years compared to those with more unfavorable lifestyle factors. Now, this study does not look at breast cancer treatment, breast cancer stage, or any of the other important things which determine survival. They're just looking at these lifestyle factors. On the horizon, there are a number of ongoing trials testing lifestyle change programs in Italy, Germany, the United States, and Canada. And those studies will be reaching maturity over the next 5 to 10 years, and they should hopefully be able to tell us about prospective things that, prove once and for all in prospective trials the effect of a healthy lifestyle on cancer risk and cardiovascular risk. If people are having trouble kind of changing their lifestyle, that's very common. We're all set in our own ways. At the end of a long day, it's difficult to come up with something healthy to eat. And certainly by the end of a long day, it's also hard to fit in exercise. We do have a lifestyle medicine program at St. Joe's, which is focusing on the 6 pillars of lifestyle medicine. And those pillars are managing stress, positive relationships with family and community, a plant-based diet, increasing physical activity, avoiding risky substances, and getting enough sleep. It seems pretty simple, but we all know that it's hard. And the lifestyle medicine team can meet with you. They can either do a consultation, or they can actually even enroll you in an 8-week intensive with cooking classes, exercise coaching, and these interventions can really transform people's lifestyles and really help you on the way to a healthier life. I also want to end by talking about the impact of COVID-19, the COVID-19 pandemic on cancer outcomes and specifically on breast cancer. In March of 2020, we had to really slow everything way down at St. Joe's and at IHA. We were, with the help of video visits, able to continue seeing patients as we needed to. We were able to bring them into the office safely with social distancing. We had to slow down mammography, and we had to make our visits longer so we could clean between patients and allow for social distancing within our mammography facilities. But we are back up to speed. We believe that we have a safe facility, but some people are still afraid to come. And it's those people who we want to reach, because we're afraid that their fear about coming into the hospital is going to lead to them potentially having a later stage of diagnosis and fewer treatment options. So if you have a friend or a neighbor who's been afraid to get a mammogram, I would really encourage you to offer to give them a ride, or tell them that you had a good experience with your last mammogram. I always hear good feedback from about our mammography program. And so I would encourage everybody to either get your own mammogram or talk to a friend and encourage them to get one, and not just in October. So that's all I have today. I'd like to introduce Dr. Jill Knapp. She's the director of our breast imaging program here at St. Joe's and across the region, and she's an amazing radiologist. So I'm going to let her start talking as soon as I stop sharing.
Okay, hi. Thank you for that introduction, Dr. Breslin, and thank you for your interesting talk and for the plug for screening mammography. I'm going to be talking about breast cancer screening and mostly about screening mammography. The statistics around the incidence of breast cancer are a bit disturbing. It is the #2 cause of cancer death behind lung cancer in the United States. It's the most common non-skin cancer in women. And 1 out of 8 women will develop breast cancer in her lifetime. So if you most likely know someone who has gone through the breast cancer treatment. So 1 out of 8, that's a lot of women. But on the flip side of that, the vast majority of women being screened with screening mammography will never have breast cancer. For a screening exam to be effective, it must save lives. Does earlier detection by screening mammography result in a decrease in breast cancer deaths? And the answer to that is yes. Screening mammography prolongs survival and decreases death from breast cancer by allowing early detection. The goal is to detect disease before it causes a noticeable problem in a woman's breast. So how do we know screening mammography works? Screening mammography began on a wide scale in the early 80s. Less than 10 years later, and this kind of goes back to Dr. Breslin's that death curve she showed from the mortalities of different cancers. So in 1990, the US breast cancer death rate began a sudden and steady decline. By 2000, the death rate had declined by almost 20%, and presently 40% reduction in breast cancer mortality attributed to screening mammography. So who gets screened and when? And I'm really talking mostly, actually almost entirely in this talk about the screening of average risk women. 75% of women diagnosed with breast cancer have no identifiable risk factors. So the majority of women diagnosed with breast cancer have no known risk factors like family history, which is a commonly mentioned one. So as Dr. Breslin had mentioned, the NCCN, it's easier to say that than National Comprehensive Cancer Network. That's kind of a consortium of experts in all the fields of medicine that provide guidelines on prevention and screening and treatment of all different kinds of cancers. So NCCN, the American College of Radiology, and the American Society of Breast Surgeons recommend a screening mammogram every year beginning at age 40. Again, this is for average risk women. And to continue screening mammography as long as overall health is good and life expectancy is around 10 years or more. Now, the American Cancer Society recommends a yearly mammogram beginning at age 45 with an option to start at age 40, and then every other year, age 55 and up. And then the USPSTF recommends every other year from age 50 to 74, which is also Trinity's standard. So the model of yearly screening mammography beginning at age 40 results in the 40% mortality reduction. The American Cancer Society model, if that's followed, is roughly a 31% reduction in mortality. And these are derived on risk modeling. And then the task force, if that model was followed by everyone, that would result in a 23% mortality reduction. Excuse me just for a minute here.
I apologize for the brief interruption. We're having just a slight technical difficulty.
Thank you. I think I have it under control now. Thank you, everyone. Okay, so the Society of Breast Imaging, and I've included their website because it's a really nice resource, and they do have kind of clinician-friendly and patient-friendly resources on that website. So I've included that. The Society of Breast Imaging has attempted to address this confusion between all the conflicting guidelines on their website, and they coined the hashtag "End the Confusion." So a few of the things I wanted to touch on about the annual screening mammography beginning at age 40 is that more than 40% of the year's life lost to breast cancer, so almost 50% of the year's life lost to breast cancer, are among women diagnosed in their 40s, which is somewhat intuitive because they are younger women. But that is still a large percentage of the years of life lost attributed to women diagnosed in their 40s. There's really no scientific or biological reason to delay screening until the age of 50. Breast cancer incidence increases substantially around age 40 and continues to increase after age 40. And the most rigorous scientific studies have shown a decline in deaths from screening women beginning at age 40. Even the task force, which has sort of the most the shortest duration and less number of screening mammograms, that's the 50 to age 74 every 2 years, they even acknowledge an increase in total lives saved and life years gained in women who have started screening in their 40s. So why is there disagreement at all then? And the basis of it is the desire to limit perceived harms and risks associated with screening mammography. So some of the things that I'll talk about specifically about this is that it is a bit of an uncomfortable exam. We'll go into more on that. The concerns over radiation risk, the concerns over false positive screening mammograms, and false negative screening mammograms. When I was preparing for this talk, I had only heard this for the first time. I've been in practice for over 10 years, and I heard to it referred as a screaming, not screaming, but screaming mammogram. And so the physical component is an uncomfortable exam. There's also a mental discomfort with the exam, the anxiety associated with the procedure itself, and of course with the possible outcome of the procedure. So it's an uncomfortable exam. I love this cartoon by Dr. Mussey because she says, that reminds me, I need to get my mammogram. And for all of us that have had mammograms, we can certainly, understand the steamroller comparison. So a screening mammogram consists of 2 views of each breast. Those of us that have had it are well aware of this and what it feels like and what it entails. But right here, this is what a mammogram looks like. This is the cranial caudal view where the breast is literally squeezed from above. This is the MLO view where the breast is squeezed from the side. And the squeezing is no joke. This is kind of a diagram, if you will, some pictures of the compression. But the compression is actually pretty important. It keeps that breast tissue still so that we radiologists can see the microcalcifications, the little microscopic deposits of calcium in the breast that can be an early sign of breast cancer. And that compression is important to separate the tissue so that we can see as much as possible. But that's not it. And these are models, please be aware, these are not actual patients, but pulling the tissue is important. And the technologist is tasked with really literally trying to pull that breast away from the chest wall as much as possible so that we can visualize that breast tissue that is against the chest wall and that extends up into the armpit in some women. So that discomfort is brief. And the result of the discomfort is so important that the technologist can get the best quality images so that we can give you the best study and the most accurate read on your screening mammogram as possible. Now, just real briefly, I did come across some tips for tolerating a screening mammogram. Anxiety, breast structure, and pain tolerance of each individual patient are all factors in how well people tolerate a mammogram, but there are some things that we can control that might help. So the timing of the screening mammogram, try to schedule your screening mammogram 1 week after your menstrual cycle if you are still having them. That's when the breast tissue tends to be the least tender. Reducing your salt intake and limiting caffeine 1 week prior to your mammogram may help by minimizing water retention and bloating and minimize the sensitivity of the tissue. If you're able to take a pain reliever like acetaminophen or ibuprofen, sometimes taking a pain reliever 1 hour before your appointment can help. Of course, wearing comfortable clothing, two-piece outfits, and comfortable shoes is important. Don't forget to not apply powders, lotions, deodorants, or perfumes so that you don't have to worry about cleaning those off when you're actually in for your exam. And then when you're waiting for your mammogram in the waiting room, try different calming techniques. Breathing exercise, relaxing music were some of the suggestions. And this was one that I saw multiple times that didn't ever really occur to me, even having had mammograms myself, is they said, try to just keep your feet and trunk forward and keep your body relaxed. Don't try to twist, and try to just relax so that the technologist can position you as necessary. And most importantly, communicate with the technologist. She's there to try to get the best test for you, but also try to make you as comfortable as possible for that exam. So another of the concerns about the harms of mammography are radiation risk or perceived radiation risk. And in radiology, we really try to adhere to what's called a LARA, as low as reasonably achievable, to try to reduce radiation across the board for all patients. The effects of radiation on breast tissue varies with patient age. Younger patients' breast tissue, and really specifically under age 40 years of age, that breast tissue is more radiosensitive. And then of course, the effects of radiation vary based on dose. The dose delivered varies based on the individual patient's breast thickness and breast composition, percentage of fatty tissue compared to percentage of dense tissue, and I'll touch on breast density shortly. So this is just for a frame of reference. These numbers aren't super accurate because of the ways that dose and effects of radiation can vary. But a standard forward-view screening mammogram imparts about 0.2 millisieverts plus 3D mammography or DBT, and I'll be talking about that a little later as well, imparts a total of 0.4 millisieverts. However, this is magnitudes below the governing body for screening mammography safe limit. So it's magnitudes below that safe limit. And just as a frame of reference, we all experience approximately 3 millisieverts of background radiation per year just by walking around this earth. So the dose that we get, even with a mammogram, even with 2 mammograms every year in certain situations, is still magnitudes below what is considered harmful. And the concerns about the risk are assumed based on a linear extrapolation from much higher doses where there is known risk. So risk is known to occur at 100 millisieverts. And again, we're talking multiple magnitudes below that risk. Harm from radiation is not detectable below 100 millisieverts. So this harm and this risk is extrapolated downward from 100 millisieverts when this linear extrapolation model is probably not accurate, but it's the most conservative. And just really briefly, I wanted to include something that the International Organization for Medical Physics, and this is a quote, "The phobia of risk due to exposure to low level being anything less than 100 millisieverts, radiation should not incite the patients to delay or defer any medical examination or medical imaging that may otherwise cause risk to their health. And delaying or foregoing screening mammogram," and this is me talking, not the quote anymore, could certainly be a risk to a woman's health. So another concern, and this is real, are false positives. False positives exist, like medicine in general, but definitely with imaging. No imaging is absolutely perfect, so false positives can occur. So again, to put that into perspective, per 1,000 women screened, approximately 100 women are called back, which means they have to come back to the mammography department for additional mammography views and sometimes breast ultrasound. Of those 100 called back, only 5 of them will be diagnosed with breast cancer. So 95 out of 1,000 women screened are going to experience a false positive. And out of those 100 called back, 19, well, 14, because 5 of these women will be diagnosed with breast cancer, 14 of these women will have a minimally invasive core needle biopsy, which is also considered a false positive. So certainly something to be aware of and something that we try to reduce. There are also false negatives. About 85% of cancers show up on a mammogram. So 85%, that's pretty good, but that means that 15% of cancers aren't showing up on a mammogram. And in dense breast, which I'm going to talk about next, that number of cancers that show up on a mammogram in a dense breasted woman are even less. So dense breasts on a mammogram, we're catching even fewer of those cancers. So what is breast density? So on a mammogram, the black tissue, the dark tissue is fatty tissue. And the white tissue we have here, muscle, vessels, the fibrous tissue that gives breast its shape, and then the glandular tissue that at some point in our lives may have been involved in lactation contributes to the white tissue. So this is a fatty breast. Then we go to a scattered areas of fibroglandular density, and you may recognize some of these words from your radiology report if you've ever seen them. And as the amount of fat relative to the amount of glandular tissue decreases, the breast density increases. So this is fatty, scattered areas of fibroglandular density, heterogeneously dense breast, and extremely dense breast. Now, 50% of the population have non-dense breasts. But 50% of the population have dense breasts. And just as an example, you can see here, these are lymph nodes. The density of a lymph node is similar to the density of a mass. So you can a mass or a nodule or a breast cancer. So you can imagine if there's a mass in this white tissue, it could certainly be obscured. What about breast density and risk? So breast density, the classification of breast density is somewhat subjective. As a matter of fact, there have been studies that have shown that only about 50% of the time do radiologists agree with each other on classifying a breast as non-dense and dense. So they've come up with objective software measurements, but we see that those are also inconsistent. So there is variability in the classification of breast density, but breast density also varies over time. With the age of the patient, as the patient ages and that glandular tissue atrophies, the density tends to decrease. And with the weight of the patient, this is an example of a woman 1 year apart. This is her screening mammogram 1 year where she would have scattered areas of fibroglandular density. She underwent a surgical procedure and had significant weight loss. And 1 year later, as that fat composition in the breast decreased, she is now dense breasted on mammography. Hormone intake can also affect breast density. How about the risk associated with breast density? Well, as I had kind of alluded to, there is a masking effect, meaning that dense breast tissue can hide masses. Now, the next one, density is an independent risk factor, is debated by experts, and it is fairly controversial. But it is also intuitive because breast cancers arise from that glandular tissue. And so if one has more glandular tissue, one would think that there would be more opportunities for breast cancer to arise. But again, this is that risk factor is controversial. But on average, the woman with a heterogeneously dense breast has a 1.2 times increased risk compared to a non-dense breasted woman, and an extremely dense breasted woman has a 2-time risk compared to the average woman. So what can we do for women with dense breasts? And so I'll just talk briefly about supplemental forms of screening. And supplemental is an important word because none of these things replace mammography. Mammography is still the #1 breast cancer screening tool. I put 3D mammography in quotes because that's not really, it's a bit of a misnomer, but it's just a lot easier to say than digital breast tomosynthesis, which is the formal term, also known as DBT or TOMO. So with this was initially kind of thought of as a supplemental form of screening, thinking that it was only helpful in women with dense breast. But now it's really become the standard of care for mammography. The positioning and compression are the same, unfortunately, but so it feels just like getting a mammogram, but the X-ray tube moves in an arc to take multiple low-dose exposures of the breast. The advantages being that normal overlapping tissue may not simulate disease, which would decrease those callbacks, decrease those false positives, and has been shown to do so. And it also, the TOMO prevents normal overlap from obscuring or masking breast disease. So TOMO has been shown to increase cancer detection. 1 to 3 breast cancers identified per 1,000 women compared to standard 2D mammography. And that gain in breast cancer detection is similar for dense and non-dense breasts. Now, the disadvantages are that it may disrupt the imaging of calcifications if we're using TOMO alone with a computer reconstructed synthetic 2D image of the breast. But to overcome that, we have included a 2D mammogram with the TOMO, which does result in slightly increased radiation dose, as I mentioned on my slide about radiation. Then this doesn't affect you ladies, but there is increased time to review the images, double the time to read the study. There's very slightly increased time to obtain the images. So the discomfort from that compression is just a little bit longer. Now here's just a real quick example. Here we have a dense breast. This is a zoomed in 2D image of that dense breast. Okay, there might be something there, but on the TOMO image, you really see the spiculations of that breast cancer pop out. And just another example here in a dense breast. Standard 2D mammogram image, and it really pops out on the TOMO image. Another supplemental screening modality that I do want to talk about, because I do want you to be aware that it exists, but we do not offer it in our facility, is screening ultrasound. Now we do ultrasound, lots and lots of diagnostic ultrasound. It's a very powerful tool, but we do not offer screening breast ultrasound. This is just an example over here of a small breast cancer in a breast on ultrasound. The positives of screening ultrasound are that it is well tolerated, relatively inexpensive, and there is no ionizing radiation. The negatives are that it does have a high false positive rate, meaning ultrasound finds more things that prompt a biopsy that is benign. Only 10% of the biopsies prompted by ultrasound only were positive, 10%, compared to the 25 to 40% positive predictive value published for mammography. Now, screening breast ultrasound does find an additional 3 to 4 cancers per woman screened. So 3D TOMO, 1 to 3 additional cancers, breast ultrasound, 3 to 4 additional cancers. Breast ultrasound is highly operator dependent because the technologist freely is kind of moving the ultrasound probe over the breast. It's time consuming to perform. It's for the most part not standardized, and it's also not as sensitive, meaning that breast cancers can be missed with ultrasound. No imaging is perfect. Then there's also screening breast MRI. The positives with screening breast MRI is this can provide a supplemental 15.5 cancers per 1,000 women screened. So TOMO, 1 to 3, ultrasound, 3 to 4, incident screening breast MRI, meaning the first round of screening has been shown to find in the teens of cancers per 1,000 screened. So it's very sensitive. It finds small, high-grade cancers. And again, there's no radiation. Now, the negatives of screening MRI is it requires intravenous contrast with a gadolinium-based agent. Now, we know that gadolinium can deposit in the tissues long-term. Thus far, there seem to be, and there are for sure ongoing studies, that there have been no negative effects of this gadolinium deposition, but it does require an IV for that study. There are still false positives comparable to those seen in mammography. The exam is time consuming. For a standard full protocol breast MRI, which we offer and recommend to our high risk patients, greater than 20% lifetime risk, it is a 40-minute exam. And it's relatively expensive. Again, relatively, because it's on the magnitude of $1,000 or more compared to several $100s. Now, some women cannot undergo, this is an example of what you would feel if you were getting a breast MRI. Your whole body is in the bore of the magnet. You're face down with your breasts not compressed in a breast coil with the arms above the head. And some women, especially with claustrophobia, cannot tolerate this positioning. So a way that we have, that we're offering to get past some of the negatives is called abbreviated breast MRI. This is a newer technology, meaning that it's not mainstream across the country, but it has been studied extensively in academic centers around the world, is that the scan time of an abbreviated MRI is decreased. So about 15 minutes compared to 40 minutes for a full protocol MRI. The cost of abbreviated MRI is decreased. $500 versus thousands of dollars. Unfortunately, this is an out-of-pocket cost, so that can be significant. But the cancer detection rate has been shown over and over again to be as high as a full protocol breast MRI. And this is offered to average risk women with dense breasts. High-risk women would still benefit from the full protocol breast MRI as of right now. And but we are offering abbreviated breast MRI as a supplemental, not replacing mammography, for average risk women with dense breasts. So please, as a little plug at the end here, schedule your screening mammogram. A paper or electronic order is required from your clinician. If you don't have a primary care provider, you can call the physician referral line listed here. You can call this number, 855 number, to schedule, or you can schedule online at stjoeshealth.org. But just as a really brief reminder, screening mammography is reserved for asymptomatic women, meaning women that have no symptoms of a breast problem. If you are having a breast problem, please reach out to your primary care provider and get a breast exam, and because a diagnostic mammogram and possible ultrasound would be the best test for you if you're having a breast symptom. And just as, and kind of back to what Dr. Breslin was talking about and imaging in the time of COVID, these again are models, but showing, yes, we are all wearing our masks in the hospital to protect you. The technologists are wearing gloves. The equipment is cleaned thoroughly between patients. We're trying to keep our waiting rooms empty enough that people can space out comfortably and reduce modes of infection transmission in the waiting rooms. So thank you very much.
Okay, we're going to go ahead and go through some of the questions. So I'll go ahead and read the questions in our Q&A. And Dr. Knapp and Dr. Breslin, if you want to go ahead and provide answers for us. First question is, what viruses are known to cause breast cancer?
So I can take that one. I was really talking about viruses which cause certain cancers, not necessarily breast cancers, but cervical cancer is a cancer that is associated with the HPV viruses. And so that's what I was talking about there.
Next question. I have heard that there is a gene PALB2 that is related to breast cancer.
Yes, PALB2 is another breast cancer associated gene. It is not associated with as high a risk as the BRCA1 and BRCA2 genes, but those patients might be candidates for high risk screening, either with MRI or more frequent breast exams, then they may be candidates for breast cancer risk reduction, depending on what their lifetime breast cancer risk is calculated to be.
Thank you. Next question, is there a concern that starting mammogram every year at age 40 and cumulative radiation exposure could cause breast cancer down the road, say in 20 years?
That's a good question. And, like I had kind of mentioned, they are not able to detect harm below that 100 millisievert level. So scientists have used what's called a linear no threshold model to extrapolate downward from there. And while we don't know for sure, because we can't actually detect that harm below that threshold level, the risk of missing a cancer by skipping screening, or the risk of delaying in your annual testing and resulting in a later stage diagnosis of breast cancer, that risk is higher than any risk of radiation. And again, some women that their breasts are being followed with mammography for an abnormality. Some of them have multiple mammograms within a 2-year period. Even with that cumulative dose and cumulative over the patient's lifetime, that risk of the radiation causing a breast cancer is magnitudes lower than the risk of not detecting a breast cancer.
Thank you. If I am high risk and only 32, should I get tested sooner than 40?
Yeah, that's a good question. And the NCCN does provide guidelines on that. What they say is that start screening with mammography. Well, first of all, have an encounter with your clinician to detect your level of risk. And to start your screening mammography 10 years before your youngest family member was diagnosed, but not before the age of 30. So in theory, screening mammography could start at the age of 30 in select patient populations. And then supplementing that in high-risk patients with annual screening breast MRI. The screening breast MRI can begin at age 25.
And I'd just like to add to that, which is that that cutoff of age 30 for beginning screening mammogram doesn't mean that we won't do a mammogram on somebody who's younger than 30. If a person comes to our office or presents to the radiologist with a suspicious abnormality that is concerning for malignancy, we will do a mammogram.
Yeah, absolutely. Thank you for clarifying that, Tara.
Next question, could you address in a little more detail the benefits of breastfeeding and reducing the risk of breast cancer?
Sure. So breastfeeding is similar to exercise in many ways, because conditions that are associated with a lower lifetime estrogen exposure, such as the ovarian suppression that comes with breastfeeding, or the lower total body estrogen that comes with having a thinner body habitus, are associated with lower breast cancer risk because there's a lower lifetime estrogen exposure.
Are fibrocystic breasts considered dense?
That's a good question. The fibrocystic breast disease is actually a tissue diagnosis, but certainly cystic disease of the breast can contribute to breast density.
And I'll add to that, because I take a lot of questions about this in the office. And a lot of my patients will tell me, oh, I've got cystic breasts, or I've got, I was told that I had fibrocystic disease. And it's important to differentiate, as Dr. Knapp mentioned, between a biopsy diagnosis, which says that you have fibrocystic breasts, which is something you diagnose on a microscope slide, and something that you detect with a physical exam. So many women will have irregularities in their breast tissue that you can feel as tiny lumps or firm areas, and those are completely normal. But but not necessarily associated with an increased risk for developing breast cancer. There are certain conditions within the fibrocystic spectrum, such as atypical hyperplasia, that are associated with a higher risk for developing breast cancer, but that requires a biopsy to make that diagnosis.
Next question. What types of prescription medications can increase risk of breast cancer?
Can increase risk for developing breast cancer? Okay. So the main medications that are associated with an increased risk of breast cancer are long-term combined hormone replacement therapy. So combined estrogen and progesterone. And we estimate that probably long-term means something more than 5 years. There was a sort of a collective discontinuation of hormone replacement therapy in the 90s when the Women's Health Study demonstrated an increased risk of breast cancer in women who'd been taking combined estrogen and progesterone. We now have sort of backed off of that sort of almost across the board prohibition and feel like it's safe in average risk women to take postmenopausal hormone replacement therapy for a period of time, something less than 5 years, to manage the symptoms of menopause. And that appears to be safe in most patients. There are some other medications that are associated with increased breast cancer risks, such as in utero DES exposure, but that's not very common anymore. And some other environmental exposures, but not the everyday medications that we prescribe for management of blood pressure and diabetes.
Is packaged organic turkey lunch meat considered processed meat?
So unfortunately, yes, primarily because it's high in salt, and that is associated with just higher processing of meat. Certainly, it's a leaner meat, and it's all about balance. And so, if the goal is to get a quality protein with lower fat, then that turkey may be a really good option. But balance that then with the fruits and vegetables and whole grains.
We have another food-based one. For lifestyle changes, it mentions a plant-based diet. Could you comment on the role of soy and its association with breast cancer development? Studies seem to go back and forth, but hint at avoiding.
So that's a very good question, and one that I get asked a lot in both directions. So the reason that people raise concerns about soy is that soy proteins or soy-based proteins, such as tofu, for example, have substances called phytoestrogens, meaning plant-derived chemicals which look a little bit to the body as if they're an estrogen. Now, there is not enough phytoestrogen in tofu or other soy-based proteins to ward off a hot flash. So anything in moderation is probably just fine. And soy protein is a good source of low-fat, high-protein, or low-fat protein that is healthy for most people in, sort of dietary proportions. Certainly, eating tofu or other products in the quantity that somebody might need to control hot flashes or menopausal symptoms wouldn't be healthy anyways. But as a general food, it is just fine.
Thank you. We know that majority of breast cancers develop in older women. Why is the recommendation to do mammograms every other year after age 50 and to stop completely after 74?
That is a good question, and I am going to refer back. I am going to look back at one of my slides because I do have some information on that.
While you're doing that, Jill, I can pop in a little bit, which is that one of the rationales for, and this is not necessarily the position of our group, but one of the rationales for recommending screening every other year is to make sure that we reach more patients. And so if mammography or access to screening mammography is potentially a limited resource, if we focus our energy on at least getting people to screen every other year, perhaps we'll cast a wider net and be able to reach more people. Also, breast cancer tends to grow very slowly, and it takes several years for a small tumor to even become visible on a mammogram. So that would be the rationale for doing mammography every other year.
Okay.
Yeah, I mean I think that's a great. I think that's sufficient answer. There was something actually published in one of my radiology journals in 2021, and it was just a review. It wasn't a randomized control trial, which is really the gold standards for trials. But they did show that annual versus biennial did result in lower stage, so every year as opposed to every other year, lower stage and less interval cancers or cancers popping up in between exams. So that's the reasoning behind doing certainly annual, but I appreciate Dr. Breslin's input on that one.
Thank you. I have dense small breasts, and my sister had breast cancer last year. Besides the 3D mammogram, should I also be getting an ultrasound?
So the first thing for that is, I think a formal risk assessment would be a really great idea. Because then you get plugged into the right clinicians to help you, number one thing, help you make those decisions, but also to determine if genetic testing would be appropriate for you. And we do not offer a screening breast ultrasound. Some facilities do, but because of that false positive rate with screening breast ultrasound and the interval cancer detection rate compared to MRI, we are offering high-risk screening breast MRI, not ultrasound. But definitely talk to your clinicians, see if being evaluated in the high-risk clinic is appropriate. A formal risk assessment would probably be a good idea.
What is your take on topical tamoxifen?
So there have been a couple of studies looking at using topical or a cream-based tamoxifen. The idea being reducing breast cancer risk by applying it in the area where it's going to be most effective and most useful, and potentially avoiding some of the side effects like hot flashes that are associated with tamoxifen. It's not yet the standard of care, so I would stay tuned on topical tamoxifen. Looks like there's another question about atypical hyperplasia. So it really depends. The standard of care is that if Dr. Knapp or one of her colleagues does a needle biopsy that demonstrates atypical hyperplasia, we typically recommend a surgical biopsy to follow that up to confirm that that's all there is. And then if we do confirm that all we have is a benign condition called atypia, which is a few abnormal cells, then the next step is to do a formal risk assessment and determine if the patient is a candidate for risk-reducing medications and lifestyle changes to reduce breast cancer risk.
Thank you. And in the interest of time, we'll take a couple more questions. For those who have questions in the Q&A, if we did not get to it, we will send out answers with our FAQ once our presenters have time to review and respond.
There was a question in the chat that I wanted to address, and that was a question about how many of the studies that we quoted had test participation representative of the U.S. population as a whole. And I think that that's really important question. The studies that the studies that are ongoing right now, the risk reduction studies, those are all studies which are intended to have a representative population in the country where the study is being performed. And the reason for that is that certain ethnic and minority groups have been underrepresented in clinical trials looking at cancer prevention. And so that is definitely a focus. Screening rates among minorities are lower than in white Americans. And so that is also a focus of the American Cancer Society and our other breast cancer advocacy groups to try to raise awareness, decrease anxiety and fear about undergoing screening, and also just broaden the availability, making it available for patients when they need it. So our breast imaging department does evening and weekend mammography appointments during certain periods of the year to try to make it more accessible for all of our patients.
Thank you. The next question I have on my screen, how long does it take cancer to form? I've read that it could be 5 years before it shows up on a mammogram. Is this correct? And if I'm having regular screenings, how early can it catch cancer?
Well, depending on the aggressiveness of the cancer, which no one can predict and no one knows until a biopsy is done, it can take a very short amount of time for a breast cancer to develop. We have detected breast cancers on the order of millimeters in size. So I don't know if that answers the question.
Well, I will just sort of back that up, just sort of with some data of looking at who is diagnosed, age and stage or stage at diagnosis, and the majority of patients who are diagnosed with breast cancer are diagnosed by screening mammography with a size less than 2 centimeters, so a size less than 1 inch, stage 1 breast cancer or stage 0 breast cancer, and this is the stage at which breast cancer is most easily cured with the greatest number of treatment options. And it's estimated, and this is just taking all comers, that it takes a couple of years for a tumor to become large enough to be identified on a screening mammogram. And so it may be there, you just can't see it. And with the very high sensitivity of modern screening imaging, I would say it may be a shorter interval before than 5 years, but the estimate a few years ago was that it takes 5 years for something to be big enough to be seen. But it may be less now, just because we have such high resolution sensitive mammograms.
Does the use of bioidentical hormones have a lesser effect on breast cancer in most menopausal women? Post-menopausal women, sorry.
So bioidentical hormones are just a way of delivering hormone replacement therapy. And the idea is that the dose and the type of hormone that's administered or prescribed is calculated for a specific woman based on her hormone levels and how her hormone levels change and symptoms change based on the medication that they're getting. My recommendation actually is that patients take set prescribed doses, because that's the way to keep your dose as low as possible with a easily quantifiable measured dose that isn't going to change based on formulation and compounding.
All right, and we'll take this as the last question for the night. What do you suggest to help with hot flashes?
Wow. So hot flashes are tough, but they usually go away with time. For people who cannot take hormone replacement therapy or who prefer not to, avoiding things like red wine, sugar-dense foods, and caffeine, particularly late at night or in the afternoon, is said to reduce hot flash severity and frequency. There are also some medications, such as antidepressants, which are given in low doses, and some high blood pressure medications, which can decrease the severity and frequency of hot flashes.
Thank you. Again, for those on the call, a wrap up after tonight's presentation, once the recording is put into presentation mode, We will be emailing out the copy of the presentation from tonight, as well as the recording, and forwarding all unanswered questions over to our presenters for a one-pager FAQ to come out with tonight's presentation. So thank you for joining us for our Wednesday Wellness. Thank you, Dr. Breslin. Thank you, Dr. Knapp. It was a pleasure.
Thank you so much.
Thank you, everyone, for tuning in.
Yes. Have a wonderful night. Good night.
Night.
All too. Thank you.